So our equation for determining total ventilation is the tidal volume that we breathe times our respiratory rate. And as we discussed, not all regions of the lung are going to ventilate equally. And the lower regions of the lung ventilate better than the upper zones. These lung zones, as we discussed, can be manipulated in critically ill patients to improve our ventilation. Our ventilation equation is our pressure of CO2 is equal to our CO2 production divided by our alveolar ventilation, and K represents a constant. Knowing a little bit about the mathematics is mostly important because it helps you understand the interplay between ventilation and oxygenation. So based on this equation, if alveolar ventilation is halved, the PCO2 is going to be doubled. And if we remember in Dalton's law of partial pressure, the total partial pressures together have to be considered. If your PCO2 goes up and you don't increase your volume, there's less room for partial pressure from oxygen. So because of this, hypoventilation, or an increase in PCO2, is going to cause a decrease in our PaO2. Unless we increase our inspired O2 to help increase the concentration to help balance this. In continually increasing your FiO2, however, does have limits. Of course, the upward limit of 100% O2, and is not a permanent fix for the imbalance of ventilation and oxygenation. Additionally, merely increasing the FiO2 while leaving your CO2 partial pressure unknown can obscure the fact that you're not ventilating properly, such as the case in a sedated but not critically ill patient who might be undergoing, for example, an MRI with sedation. If you're not measuring your PaCO2 and you're merely and you're administering O2, you may be masking poor ventilation. So the last couple of things I'd like to discuss are some ways that you can monitor your critical patients and objectively discuss their oxygenation and ventilation. There's two good equations that are important to remember. One is your AA gradient, which comments largely on your diffusion. This is your alveolar to arterial oxygen gradient. Ideally, this gradient should be very small if our diffusion is working properly. Once you start getting above 50, you're going into the significantly abnormal range. The equation, your AA gradient, is your alveolar oxygenation, which we calculate, and your arterial oxygenation, which we measure with an arterial blood gas. It's important to remember that you need to have an arterial sample. The full equation is then for your alveolar, your partial pressure of your O2 and alveolar is going to be the percent of inspired oxygen times our pressures, barometric and accounting for water pressure, your mean airway pressure, subtracted by your arterial CO2, because we know those two are related, and divided by a constant. A good approximation on the fly for this is to say that your AA gradient is going to be approximately equal to your FiO2 times your pressure factor minus your PaCO2 minus your AO2. The larger the gradient, then, the more abnormal your diffusion capacity is. You can continue to calculate this equation, making changes to your ventilated patients, both hour to hour or day to day, to have an objective way to comment on whether the diffusion is getting better or possibly worsening in your patient. The other equation that's helpful is the oxygenated index, which comments on diffusion and ventilator work. Your OI is calculated by your FiO2, your inspired O2, times 100 times your mean airway pressure, and you divide that by the partial pressure of O2 in arterial blood.